All right, good afternoon and welcome everyone. Thank you for joining us for this afternoon's webinar. My name is Meg Beyer. I'm part of the Managed Care Technical Assistance Center team, also known as MCTAC, and I'm really thrilled today to be joined by some of our OMH and OASAS partners who will be delivering some really critical information about COVID-19 program and billing updates for the adult behavioral health, Hcbs, and recovery coordination. I do want to emphasize, I know there might have been a little confusion at first, but this webinar is really only going to be focusing on adult behavioral health, Hcbs, and recovery coordination only. So for those of you who might be working with the children's population, please know that this webinar is really going to just cover information related to adult behavioral health, Hcbs, and recovery coordination. A few pieces of housekeeping before we get kicked off. I think the issue seems to have resolved itself, but we were experiencing just a slight technical difficulty on the back end where we were able to hear some of the attendees, not necessarily the presenters today, but the attendees. So if you're joining us as an attendee, we're just asking that you mute your line. I know that there might be some typing or some note-taking or some other conversation going on in the background as this webinar happens. So to make sure that we can hear our presenters clearly, we're just going to ask you, especially today, to mute your lines. It does seem that WebEx is throwing us a curveball today, so we're going to go with it. But with that, I did want to just kind of run through a couple things. Many of you are probably very familiar to my voice and to some of these details that I'm about to go through, so I'll go relatively quickly. I just wanted to say one thing, that this webinar is going to be, it's being recorded, and the recording along with the slides are going to be posted to the MCTAC website as well as shared with everyone who attended and registered. So if you want to share these with your colleagues, if you want to refer back to the information in the slides, don't worry, you will definitely be able to do that. We'll get this information posted and the recording posted as soon as we can to the MCTAC website. It usually takes us a day or two to do so. The other thing to say is that, as we do in many of our MCTAC webinars, we will be collecting questions throughout the entire webinar itself. So we have time set aside at the end for questions. We're asking, though, that your questions be related to the topic that we're reviewing today. So that would be adult behavioral health, Hcbs, and recovery coordination. We know there's a lot of questions out there related to just broadly the COVID-19 response. But we are going to focus only today on answering questions related to adult behavioral health and Hcbs and recovery coordination. So we'll do our best to get to as many questions as we can. Please know that MCTAC collects all of your questions. So even if the question is not addressed on the webinar, the state will be receiving it. We send them a giant question document after every webinar that they are able to review. So know that we are receiving those questions even if we're not able to speak to them on the webinar today. And then finally, I'd like to thank our OMH and OASAS colleagues who put this presentation together, and thank our presenters, Nicole Haggerty, Katie Merrill, and Peter Barnett, who will be taking us through this presentation, as well as my MCTAC colleague, Tara, who is running things on the WebEx backend and making sure things run smoothly and collecting all your questions. So with that, I think I will pass it along to Nicole to take us through the first few slides.
Thanks so much, Meg.
Yeah.
And thank you all on behalf of the New York State OASAS and OMH for the important work you are all doing in this incredibly challenging time. Okay. Given the nature of the COVID-19 pandemic, providers have had to quickly adjust to dramatic changes in staffing, service delivery, and outreach. Community behavioral health providers offer a critical safety net, maybe now more than ever. As such, we have worked with DOH and the Governor's Office to secure waivers that allow providers to deliver services in new and flexible ways, including the expansion of telehealth. The guidance cited in this presentation was issued just this week. However, the billing and documentation relief you will hear about is effective as of March 7th, 2020, the start of the declared disaster emergency. Okay. Can advance the slide, please? Thank you. As the state relaxes documentation and billing standards, we do also expect that programs will continue to maintain quality services and continuity of care to every extent possible. We hope that the relaxation of billing standards also supports agencies in maintaining current staffing levels. We ask that providers continue to support individuals and ensure access to essential services during the disaster emergency. Okay. The following guidance and subsequent webinar therefore applies to the full array of adult behavioral health, home, and community-based services, with the exception of short-term crisis respite or intensive crisis respite, and it also includes recovery coordination agency services, including the eligibility assessment and the initial and ongoing plan of care development. Okay. Essential services are those services that are especially relevant in the current environment. Delivery of these services do not require updates to service plans or the individual's plan of care. Essential services are simply intended to support an individual's basic needs during the disaster emergency period. And with that, I will turn it over to Katie Merrill to discuss how this will look for providers of adult behavioral health, home, and community-based services, as well as recovery coordination agencies.
Thanks, Nicole. So the essential services that we're talking about are really a reflection of what HCBS providers and recovery coordination agencies have been doing over the last 4 to 6 weeks. It may not be directly linked to the goal on the plan of care or in the ISP, but these services and interventions are necessary for meeting people's basic needs. Some examples of what this might look like on the ground include things like RAP planning, stress reduction techniques, mindfulness interventions, coping skills training, behavioral activation, and also more basic things like making sure people know how to access community resources like food and medication, education on COVID-19, how to make a mask, where to wear it, when to use gloves and the appropriate use of PPE. These are all things that we know that you're doing every day with HARP members. Next slide. So the guidance outlines a few expectations for behavioral health HCBS providers, and what this really comes down to is regular outreach to HARP members, making sure that you're getting on the phone with them or video conferencing on a regular basis, something like once a week or more based on the person's needs. And we're also asking that providers continue to take referrals and start services during the disaster emergency whenever possible. Our community-based providers are, as Nicole mentioned, a critical safety net. We're trying to keep people out of hospitals and safe in their homes, and we really believe that these services can support people in staying safe, home, and appropriately socially distanced. Next slide. For recovery coordination, we're asking much the same thing, that you're continuing to outreach members. People who you've previously assessed, you may want to reach out to them and find out if they need new or different services. You can also make appropriate referrals to care management based on people's changing needs throughout the course of the pandemic. Next slide. Something we're really excited about in this guidance document is the change in documentation requirements. I know from speaking with many of you that there was a lot of concern around things that just aren't linked to the individual's goal. There's a high need for emotional support right now. Clients are dealing with a lot of increased anxiety, and so some of that may not have previously linked to their service plan. So what we are saying is that you can provide these essential services. You don't need to rush to update the ISP or request a change in the plan of care through the care manager or recovery coordinator. Also, signatures are not required at this time. So where you may have needed a hard signature for something like a Psyches release or a HIPAA release or a service plan, you can now document that verbal consent in the client's record. That could be in a progress note. You could write it in on the signature line of the document or wherever it makes sense to put that in the chart. And then we're also just asking that you document all of your outreach efforts. So if you've been reaching out to someone by phone, email, text, and they're not responding, just making sure that you're noting that somewhere in the record. For unsuccessful outreach attempts, it wouldn't need to be a full progress note, but just, jot down the day and time and perhaps the method of how you've tried to reach them, because we want to make sure that we're really capturing all of that good work that you're doing. Next slide. So as we kind of transition our conversation over to the reduced billing requirements, I just want to kind of reiterate what Nicole said earlier, that our goal here is to sustain the service system, to ensure continuity of care and high quality services, and to keep the staffing levels maintained wherever possible. This does not change the core values and principles of HCBS. The services should still be of a high quality, person-centered, recovery-oriented, and collaborative with other providers. You're still going to be communicating with care managers and other collaterals, but we recognize that there may be challenges with engaging some HARP members. We have heard that many providers are perhaps reducing the duration of services but increasing the frequency. So twice a week for a half hour or daily for 15 minutes instead of 1 to 2 hour sessions. And that's working well for a lot of HARP members. But there are those who really struggle to engage by phone or video conferencing. And so the reduced billing standards that we're going to talk about may help capture some billing for those clients who are harder to engage. And with that, I'll give it over to Peter.
Hi, so my name is Peter Barnett. I'm with the Office of Finance here at OMH, and I'm joined by Gwen Diamond today. We're going to be walking through the revised billing guidelines today and taking any specific billing questions to the extent that we have time at the end of the slides. I want to just reiterate what Katie said and emphasize that the release of this billing guidance, which reduces some of the contact standards for adult behavioral health HCBS services, is intended to stabilize provider Medicaid revenue during this disaster emergency, where the nature of services with enrollees will be colored by social distancing, quarantine, illness, and it's really our hope that these measures help to sustain provider staffing levels and the capacity to continue to serve clients during these really extraordinary circumstances. So here on slide 12, we're walking through the minimum billing requirement changes. For the duration of the disaster emergency, which again I'll say was effective March 7th, the state is reducing the minimum time requirements to submit claims for adult HCBS services. In recognition of the challenges associated with telehealth delivery, for 15-minute billable units of HCBS, the first billable unit gets qualified with a minimum contact of 5 minutes, and then additional billable units can accrue in 15-minute increments as they do under the existing billing rules. So we've set forth some examples on this slide. If you have a service that's up to 4 minutes, that is not a billable duration, but 5 minutes to 19 is a unit of service where it had not been before necessarily. 20 to 34 minutes is 2 units of service, and so forth and so on. The detail on the services and the rate codes that this new 5-minute initial contact apply to are detailed on the next slide, slide 13, if we can move forward to that. So the 5-minute initial contact will apply to the plan of care development ongoing, which is rate code 7781, psychosocial rehabilitation, community psychiatric supportive treatment, peer supports, residential support and habilitation, family support training, and transitional and supported employment. And you'll note that these revised standards do not apply to assessments, to groups, to hourly or daily rates, or to transportation services. There are, however, 2 hourly billed services under HCBS which have reduced billing standards as well, and these are covered on the next slide, slide 14. We can move forward to that slide. For educational support services, which is rate code 7805 only, and pre-vocational services, which is rate code 7801 only. The first billable unit is qualified with a minimum contact standard of 20 minutes, and then billable units accrue in hourly increments just as they would under the existing billing guidelines. So for example, you see 0 to 19 minutes is not a billable service. 20 to 79 minutes is a single hourly unit of service. 80 to 139 minutes becomes 2 units, and so forth and so on. The next slide, slide 15, will give you some information on billing modifiers, and it's important to understand the requirements for billing modifiers for both the telehealth and for claims under the revised duration standards for the disaster emergency. These modifiers are required to appear on the claim. And so here again, we're giving you 3 examples. If a service is delivered in person and under the existing billing requirements, there's no need to include a telehealth or a catastrophe disaster-related modifier. Those are the GT and the CR modifiers respectively. But if a service is delivered via telehealth and existing minimum requirements have been met, then the GT telehealth modifier should be added to the claim. Lastly, if a service is delivered via telehealth and the current minimum requirements have not been met, but the minimum requirements under this revised COVID-19 flexibility have been met, then we should see a GT telehealth modifier and this new CR, which is the catastrophe disaster-related modifier, should appear on the claim. Again, that's if you're making or utilizing the reduced 5-minute or 20-minute, respectively, duration for the first unit of service. So I believe in the adult HCBS, the rate codes will use the GT modifier for telehealth. There is a nice reference document on the OMH guidance on COVID-19 webpage that's entitled Telehealth Modifier Use for OMH Licensed or Designated Programs. That will give you a compendium for all of OMH's programs at the rate code and procedure code level and detail which modifiers for telehealth are appropriate to include on the claim. And the link to that guidance is included in our guidance documents as well as at the end of this PowerPoint. So I'll emphasize too that you can submit additional questions on billing or other aspects of the guidance today to the transformation@omh.ny.gov mailbox, and we'll endeavor to answer your questions as timely as we can, or to picm@oasas.ny.gov. We will review these questions and provide answers through a FAQ process that will get subsequently posted to that guidance website. So I think at this time we'll reserve the balance of the webinar time for questions, and I'll turn it back over to Meg to moderate those questions. I think there's a chat mailbox that participants can use to offer those questions.
Yes, thank you, Peter. We've been getting a lot of questions, actually. So folks, if you do have more that you haven't chatted in just yet, please do continue to send them in. My colleague Tara and my other colleague Yvette and I are monitoring them, and I'll be now reading through some. So before we dive into specific questions, I noticed that we got a couple questions related to the HIPAA-approved platforms. And so I'm wondering if the best place for folks, if they have questions about, what is HIPAA approved for a platform for doing telehealth, should we refer people to the OMH guidance page where the FAQs are?
This is Gary Weisskopf. Yes, the FAQs are helpful, but just so people know that CMS has suspended enforcement of HIPAA for the purposes of telehealth, and any phone that can have audio and video can be used. There's a wide variety of platforms that this can be done on, and the OMH frequently asked questions, which I don't know if we have a link to in the presentation or not, but we have that information specifically identified in one of the frequently asked questions on our guidance page under the COVID FAQs.
Thanks, Gary. Okay, so diving into some specific questions here. Let's see. All right, so is it considered appropriate to use text and email for outreach with proper consent?
So, hi, this is Nicole. So text or email may be used for outreach, but in terms of this billing guidance, the telehealth definition is as stands, which expands to telephonic and includes paraprofessionals to be able to provide services via telephonic or telehealth using video applications. However, at this time, it does not include text or email in terms of the Medicaid billable units.
Thank you. Okay, our next question that we have is, since unit duration has been reduced, will the daily maximum be increased for some services?
We'll take that back. This is Gary, but the
Okay,
intent was
sure.
not to increase the amount of services unless, that's what the person needs. The intent was to provide more flexibility in a time when it's much more difficult to engage with people and to ensure that providers can be sustained. So if you were to do the normal amount of time, the intent isn't to say take, 5 minutes and multiply it by 10 if you didn't get 10 units or something like that. But we'll take the question back.
Okay, so there's been a couple questions about maximum units for some of the services. I'll ask, but if this is something that has to go back, the state will be receiving these questions, so just do know that. It looks like the maximum units set for each HCBS service at one time, do these continue to be in effect for the duration of the disaster emergency? It looks like on slides 13 and 14, Tara, I'm not sure if you want to go back to those. All of the services listed there had maximum limits, and do these still stay the same?
Yeah,
Yeah, I think
Peter,
that.
I'll jump in.
Go ahead, Peter. Go ahead, Peter.
Just to reiterate, okay, we'll take that question back for consideration,
Okay.
but this guidance does not change the number of allowable billing units in a given time period or day.
Okay. And for those folks who are asking about the slides and the recording, yes, you will definitely be able to receive these. We'll be posting these to the MCTAC website and circulating them to you shortly. So fear not, you'll definitely be able to have access to this. Okay, so this is a question about the CR modifier. If a provider is using the CR modifier, is this something that is noted on a progress note, or will billing be submitted with this modifier?
So the actual billing and claiming process will include the addition of that CR modifier when the bill gets submitted. It's a modifier to procedure code. It does. I think our program would like to see notes in the client's record on the modality of telephonic delivery, and they may want to comment further on that, but the CR modifier is a billing modifier.
Okay, thank you. Let's see here. Okay, I think someone is asking, are collateral contacts billable for peer empowerment supports? Is there any need to document outreach efforts or attempts such as voicemails, emails, text messages, etc.? And we can take that one back.
Can you repeat that question?
Yep. Yeah. Sure. Yep. The question was, I think it's actually two in one. Are collateral contacts billable for peer empowerment supports was the first part. And then is there any need to document outreach efforts or attempts such as voicemails, emails, text messages?
We are encouraging providers to document outreach attempts even if they're unsuccessful. So that would include if you left a voicemail or a text message for someone. That wouldn't need to be a full progress note. The agency could choose if they want to do like a non-billable note or maintain a contact log. So we are asking that they document those attempts. As far as collateral for peer, we did not include that in this guidance, so that is not something that has been allowable under BHHCBS.
Thank you, Katie. So this is a question about PSR. For PSR, there is an off-site and on-site difference in pay rate. For phone calls, can you clarify which rate we should be using?
On-site.
On-site. Thank you.
Yes, on-site.
Got it.
But it's important to keep in mind that telehealth and telephonic are service delivery mechanisms, right? And you're not actually, it's not a different service. If you're not going out into the community and actually meeting them, then you would be on-site, and you'll be noted in the billing that you're using telephonic and that it's during the crisis situation with the modifiers.
Got it. Thank you. Okay, let's see here. Next, okay, so just for the state to reiterate, when are these changes effective as of?
March 7th, 2020, which is the date of the declared disaster emergency.
Thank you, Nicole. Okay, let's see here. Got a couple more minutes, a couple more questions. Someone's asking if authorizations need to be obtained from each managed care organization to use the appropriate telehealth modifiers for HCBS, or if the current authorizations for HCBS prior to telehealth would automatically be modified to use the telehealth modifiers.
Yeah, no, you don't need to get new authorizations for the individual. We are flexing the way the services can be delivered. The authorization for the service was already previously granted. You don't have to go back and get a new authorization. If you were to expand the services or change them in a way that would have required a change before, that would probably require you to go back to the plan.
Okay. And one more, this is another HCBS MCO billing question. Someone's asking if MCO billing systems are ready to accept the procedure codes and modifiers for telehealth services.
We've not heard that there's been a problem to this point, and if somebody does have a problem, they should let the Office of Mental Health or OASAS know.
Okay, thank you. So with that, I think we're pretty much out of time, and I just want to see if there's anything else that the state wanted to emphasize or share before we wrap up the webinar today.
I think just a huge thank you to all of our providers for the work they're doing. We've heard from many of them over the last few weeks, and we know that a lot of great work is happening with people over the phone and video, and we recognize that and thank everyone.
All right. Well, thank you to all of our presenters. Thank you to my colleagues Tara and Yvette, who have been helping with questions, and thank you to everyone who joined. Like I said, this is being recorded, so we will post this along with the slides as soon as possible. And all of your questions, even though we did not get to all of them, are going to be sent to the state, so they'll be able to review them and look them over that way. So thanks, everyone.